Have the patient just, fixate on an object, on the wall. Make sure it's not like a TV or anything that moves, like a pendulum or a grandfather clock or something like that, because we do want their eyes to be relatively still. Because again, just like anything, the first thing that you're going to start is with your inspection. And we're going to systematically chop it down, as you can see here in the notepad. So we'll start with the eyebrows. Again, I'm not going to go into it, but everybody remembers from the head and neck exam what we're assessing for in the eyebrows. Look at the actual position in the eye. You can check out for an exophthalmos. One of the big things I want to point out, all right, is something known as raccoon eyes. Has anybody ever heard of that term, raccoon eyes, before? All right. In any type of head trauma, all right, so if a patient, let's say, is a football player or a soccer player or hockey player, or somebody's just doing a Spartan race and they trip, they fall, they hit their head. One of the biggest things that you're concerned of is a closed head injury, whether it's a subdural or a subarachnoid hematoma. Both of them are, yeah, it's really burning in here. Both of them are very, very, very serious. Now, who was the skier a couple of years back? Do you remember her name? She was skiing. I think she was a model or something. She fell, and then a couple of days later, she died. I honestly... Who was it?
Tasha something.
Tasha something. So basically what happened was this individual was skiing, and from what it sounded like, she took a nasty fall, she hit her head. Obviously, who knows what the clinical symptoms were. Could have been a little lightheadedness, dizziness. Hey, anybody that played any kind of sports, or if you accidentally hit your head on something, you stood up too strong, you're going to experience a little lightheadedness and dizziness, right? Well, the problem with closed head injuries is you don't go from, I'm feeling a little bit worse, yeah, now it's starting to get a little worse. It doesn't really take, you don't really see deteriorating neurological status from, days and days on end. Usually what happens is somebody seems to be fine, and then they plummet, all right? Because the body does a really good job at compensating. It's what we call, you'll learn in 5th semester, principles of shock. All right, so the body does a really good job trying to compensate. Problem is, it'll decompensate very, very quickly. So somebody's neurological status can deteriorate relatively quickly, where they start to experience slurred speech, they actually start to experience weakness, different types of numbness, ataxic gait, situations like that. One of the signs that you actually may see on this clinical examination is raccoon eyes. This is what raccoon eyes looks like. Let's see. That is raccoon eyes. And they call it raccoon eyes because if anybody's ever seen a raccoon, you'll see the discoloration in the lower part of the eye. All right, now you also see some significant erythema or redness in the sclera. We'll work through that. But these are signs of a closed head injury. Now, what would be your disposition, or what would you do if you saw a patient like this? They came to your office, "Doc, I have a headache," and this is what they look like. Yeah, they need to go to the ER. They're going to get a CAT scan, and most likely they're going to get monitored, maybe even drained. So raccoon eyes is something that's very, very important, especially those that want to get involved with managing concussions. You really always need to be on the lookout for raccoon eyes, all right? Now, you may also see some swelling, okay, around the orbit. Basically, that could indicate any type of facial fracture or facial trauma. Any discoloration or any swelling around the orbit really probably should warrant an ER visit because if there is enough trauma to actually show some type of clinical signs on the orbit, you have to take pictures on the inside because we have no idea what's going on in there. We don't know if it's a skull fracture. We don't know if there's any bleeding within the epidural or subarachnoid space. So like I said, if you see any kind of discoloration, or if he really sees like one eye or one part of the orbit is really inflamed, it's really tender, I would always definitely err on the side of caution, have him get sent to the ER so that an appropriate CT scan can be done and we can confirm or, hopefully rule out any type of closed head injury. The reason why I'm honing in on this is because, like I said, patients may come to your office, they may seem fine, and if you miss some of these signs, they can go home, they may be fine, the next day they may be okay, and then by that afternoon, they could be having severe neurological deficits and, death. So always be on the lookout for any evidence of raccoon eyes or nasal or orbital fractures. Does anybody have any questions on that? Okay, so now Dr. Sherman, I think they like to call it like the Sherman 21 because it's like literally like 21 or 30 items or whatever it is. It's very extensive, all right? Now I'm not going to go through each and every one of them, but there are some things that you do want to be, on the lookout for with regards to the eyelid and then as well as into the sclera. Has anybody ever had a sty before? Yeah, one? Anybody know what that is? It's something known as a hortuleum, and you can see it here on your notepad, all right? The hortuleum is usually going to be on that lower lid, and it almost looks like a pimple on the lower lid. They're painful, they're red, they're swollen, all right? This is, an infection. People are rubbing their eyes, they're touching stuff, so the moral of the story is, yeah, that's why you wash your hands. That's why you really want to try to avoid rubbing your eyes and irritating it because you can get a sty. So how'd you treat it?
Eye wash.
Yeah, eye wash, hot compresses usually, kind of work. Obviously, if it gets to a point where the sty is getting bigger and it's really just red and painful to the point where the patient's having difficulty, opening and closing their eyelid, that's where you probably want to refer to, an optometrist or ophthalmologist because sometimes they actually need to have antibiotics, either an eye drop or some type of cream, okay? So styes are relatively common. Now the lacrimal apparatus, all right, anybody remember where the lacrimal is? Is it on the nasal side or is it on the lateral side? It's on the nasal side, exactly. What does it do? What comes out of the lacrimal apparatus?
Tears.
Yeah, that's where your tear duct is, correct? So you want to see, and if you're looking on the nasal side, you'll see if there's any, evidence of dryness, if it's red, or if it's swollen. All right, you'll see a swollen lacrimal apparatus. All right, so you want to kind of just concern yourselves and see if you find that. Now, let's dip down here to the conjunctiva, all right? You have two types of conjunctiva. You have a bulbar, which is that white that everyone always sees, and then you have the palpebral. Everyone can see that here in my eyes?
We both do that.
In the event of an emergency, exits will be located on either side of the aircraft. So yeah, you have two types of, I love it, two types of conjunctiva. You're looking for different stuff, but again, like I explained before, there's some definite clinical significance. Now, what if I told you that you can see if somebody's anemic by looking in the eye? Would you believe me?
Yes.
I hope so, because are they red or are they pale?
Pale.
Pale?
Yours are red.
Are they red? Are they red?
Yes.
That's good. So, if everybody go ahead, face your partner, take both your eyelids, check them out. Right? They should be nice and red. If they're kind of this whitish pale, believe it or not, that is a physical exam finding that somebody could be anemic. Now, these are not pathognomonic signs, meaning that if you see this, they 100% have anemia. That's not true, but if you're assessing the eye and all of a sudden, hey, that's a little pale, you want to cue in. Hey, you know what? You've been a little tired lately, you look a little fatigued. Let's get some lab work on you and let's see if we see any evidence of anemia. All right? So again, these are clinical signs that help strengthen, rule in, or rule out a particular diagnosis that you're concerned with. All right, so now let's go back to the bulbar conjunctiva. So that is the white portion of the eye that we're looking at, okay? Now, it should be white. There are a few things that I want to point out. You'll see this fancy term here, the pingulecula. All right, anybody ever heard of a pingulecula? I never have before I came here myself, all right? This is a normal finding due to aging. This is what a pingulecula looks like, not that. Here. You see, this is like a yellowish thickening on the lateral side, on the lateral side of the eye. It may even look a little raised, but that's a pingulecula. This is a normal finding due to aging. So if you see something that looks similar to this, in the absence of any other complaints regarding the eye, you can just basically write it off as a normal finding. All right, so this is what pingulecula looks like.
What would the close be for someone that's not injured?
Same. Yeah, this is the same. If you're finding premature pinguleculas, and let's say like a 15 or 20-year-old, I would probably send to an optometrist or an ophthalmologist to have it, get it checked out. But this is what it'll look like. Okay. So the sclera should be white. I think that's fair to say, right? You look into somebody's eye, it should be white. If you see some differing colors in the sclera, again, outside of the actual eye itself, there is some type of organ symptomology, or I should say organ pathology, that you should be concerned with. Obviously, without looking up, what happens if you see, a sclera that has this yellowish tint to it?
Jaundice.
It's called jaundice. What organ should you be concerned with regarding jaundice?
Liver.
Liver is one of the big ones, all right? So again, these aren't necessarily signs that there is 100% liver damage, but it should basically cue you in, you know what, I may want to examine a few more other pieces of information. You'll learn next semester in lab diagnosis a whole bunch of tests that you can run, and it's a really, 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 really important class because, labs are so undervalued in what we do. You'd be surprised what you find. So definitely pay attention when you get there. All right, so white sclera, normal. Yellow sclera, again, concern yourself with jaundice. Now, bright red, all right? This is usually indicative of some type of an infection, all right? Now, Dr. Sherman was very specific, and he broke it down into conjunctiva and ciliary injections. Now, yes, we're going to workshop it. I definitely want you to know the difference. Are you going to remember the difference in practice? You may not. The big thing to remember is with ciliary injections, you're going to see basically red streaks from the nasal side to the lateral side. All right? Those are bad. All right? It indicates some type of glaucoma or an infection, most commonly. Let me show you what it looks like. All right? So you see there's some significant redness here on the nasal side. This is what you call injections. All right? These are ciliary injections. Again, if you see any type of injections, especially if it's unilateral, there's no harm in referring them to an optometrist or an ophthalmologist to basically rule in, rule out an eye infection. The last thing you want to do, especially with a sensory organ as delicate as the eye, is to let somebody go home that actually has an eye infection, and then a couple days later they have some significant eye damage. So, again, that's why I really want everyone to take the time and read over the inspection component of this exam, because, when you're staring into the eyes, you basically want to be thinking of everything on this list. Now, once you get good at this, you'll be able to assess everything within 30 seconds to a minute. But when you're starting, really just examine everything, visualize what we're talking about, all right? Kind of making sure that, all right, he's got eyebrows, he's got hair, one gray over there, I'm just kidding. No evidence of, orbital fractures, raccoon eyes, looking at the eyelids, right? Looking to see if he has a stye, also known as a hortuleum. All right, so basically that's how I want you guys to practice. You can practice this by yourselves. Look at yourself in the mirror. Look at your eye in the mirror, and then try to run it through in the back of your head with the eye and try to visualize where it would be. That's how you're going to get good at this exam. Yeah?
This might be weird, but when people smoke weed, they get bloodshot eyes, does it look the same? Or
Yeah,
is it
well,
a different thing?
yeah,
That's more like conjunctival.
I was just going to say, yeah.
We saw that the ally that had the glaucoma, and it very clearly had the ciliary injections. Remember, it's really, really red around that iris. When you smoke pot, usually it looks more like you get that sort of more of the lateral to medial. So you're not getting a lot of the blood vessels around the iris.
Right.
They're more on the periphery.
Yeah, and it's also different between bloodshot eyes. You can see how it almost looks like a webbing. These injections, that's what an injection is, right? They're streaks. Bloodshot eyes, I'm sure, has anybody if ever lifted too many weights or they've blown a blood vessel in the eye? It's purely red. You know, there's no real shade about it. So that is something a little different, right? But if you really see these injections, this kind of webbing effect, yeah, that's where you definitely want to, you know, investigate a little further. Like I said, when in doubt, you know, send them to their optometrist or ophthalmologist. If they don't have anybody, send them to urgent care.
I mean, would it be inappropriate to ask them that?
Well, you should be asking that anyway in the social history. So if it's an initial exam, you'll definitely have had drug history. And let's say if you've been treating them for a month or even a year, and now they're coming into you with this, you know, hey, you know, I just got to ask you a question. You know, have you know, excessive caffeine? You know, you could group a couple things together. You know, any excessive caffeine use? You know, you're drinking a lot more. You know, smoked any recreational drugs? They don't have to necessarily come out to it. If you smoked weed, right? You see the difference, right? You can, and that's just something that's you'll learn in practice. When you're in clinic, you'll kind of learn how to basically lead up to that question that you want to ask. All right. But no, it's definitely not an inappropriate question at all. All right, so let's recap, because I know we kind of went over a lot of stuff, and then I will get into the more technical components here of the exam. So again, the inspection is done. Obviously, the patient is sitting, I'm facing him, right? I'm assessing everything. I like to start at the top, so let me assess the actual eyebrows itself. Then I kind of want to assess each eye independently and then look at both of them together, looking at the actual orbits. Do I see any evidence of fracture? Is there any discoloration? Is there any inflammation? Any possible raccoon eyes? Looking at the eyeball itself. Is his eyeballs protruding? What was that known as? Exophthalmos. Very good. What were some of the things that if you see an exophthalmos it could indicate? Anybody remember? What's that? Hyperthyroidism, also known as Graves' disease. What else? A tumor, right? Some type of intraocular tumor, okay? So again, don't forget about some of those things. All right, then I'm actually going to look at the eyelid. Does he have eyelashes? You'll learn again, ectropion, entropions. Does he have you know, any cordyceps or styes? Now I'm going to look at, you know, to see the color of his iris. Remember, the iris is what? Known as the color portion, correct? Okay. Evaluate his iris, looking at the actual sclera. Remember, looking for the bulbar sclera. And again, don't hesitate, even though it's inspection, you know, if you need to, just tell the patient, all right, just relax, I'm just going to lift your eyelid up a little bit, okay? I come in from the side, so I never cross the body. All right, that's the key. It's going to be the key with all the rest of these exams. I come to the side and I just lift the corner. And then I can move here, that way I can get a nice view. I can come underneath. I'm killing two birds with one stone now, right? So now I'm getting the lower portion of the bulbar conjunctiva, and look, I got the palpebral conjunctiva as well. All right, so I can assess both of those. All right, so those that are interested in doing DOT exams, the eye exam is very, very, very important. Okay, so let's move down now. All right, so now let's go into the actual cornea, the lens, the pupil, and the iris. So like we said, the iris is the colored portion. Has anybody ever seen somebody that has two different color irises?
Yes.
It can happen. Big problem or? No, right? It happens. Okay. Now, you actually have looking at the iris, and then obviously, I'm going to turn the lights on so it'll be a little easier for the see. So again, I wanted to fixate on an object on the wall because basically now what I want to assess is the pupils. Are his pupils in the center of his eye? Is one pupil shifted? It shouldn't be. All right, that would be a problem. Now, let me ask you guys a question. What would happen if one pupil looked constricted and the other one is dilated? Is it the same as the iris? No big deal? Or big deal? Is it? Yeah, that's a big deal. So, what do you think? What's the first thing that's coming to your mind? Why are you saying it's a big deal? What kind of stroke? You're not wrong. Not an ischemic one.
No, it's the hemorrhage.
It's hemorrhagic. A bleed. Okay? Again, there is a condition known as anisorkia. Well, that's what it's called. That's the abnormal finding. It is a normal abnormal, but in like less than 5% of the patients, okay? So if you see it, it's very, very unlikely that it's a normal finding. Most patients that have it that are coming to your office will most likely have been diagnosed from a very young age. So they'll tell you, yes, I've been, to my eye doctor and whatnot, and make sure you get all that information. So if you do see somebody with anosarchia, they've told you that they've been to the eye doctor, make sure you get the eye doctor's name and whatnot, because you want to put that in your chart, all right, just in case they're BSing you. But let's say, he hit his head even a few weeks back, and now all of a sudden he's presenting with, abnormal pupil sizes. Again, the first thing that you want to concern yourself with is closed head injury. Now, there are some other neurological conditions and diseases that you'll learn, but, again, for the big purpose, what's going to really kill this person, quickly if we don't get them to definitive care, that's a closed head injury. So really take the time to look at the pupils. And again, don't hesitate to move the eyelid up if you really can't see, get a good, view. Remember, we want to be polite, but at the same time, we have an agenda. Our agenda is to make sure that we evaluate to the best of our ability each structure of the eye. So if we have to position the patient, if we have to move an eyelid, we do it, okay? All right, so let's first start with the actual exam component. Does anybody have any questions on the actual inspection? All right, take the time like I said, chunk it down, review it, either with a partner or look at yourself in the mirror, see if you can identify each structure. If you're not sure what something looks like, Google it. It's exactly what I did with these images. I Googled them. All right, if you forget what a pinulicula, or if you're not sure what a stye looks like, Google it. Google it as many times as you need, so that way you can it'll help visualize it, okay? All right. Everybody have one of these? No? This is a Snellen eye chart. Now, there is the handheld one, and then there's the traditional walled one. Does anybody know why we call it 20/20 vision, or 20/30 vision, or 20/50 vision? Any idea?
It's the distance that you can see it.
Yeah, exactly. So in a wall unit, how far do you stand back? 20 feet, right? So at 20 feet, you should be able to see, this appropriately sized letter, all right? So the worse that your vision gets, so if I have to stand 20 feet away and I can really see maybe line 3 or 4 or 5, well, that's something that somebody should be able to see at 40 or 50 feet away. So that's how you get 20/30, 20/40, 20/50. Okay, so that's how it works. So I happen to have my hearing is terrible, but I happen to have 20/10 vision. So what does that mean? I can see objects at 20 feet away that the majority of the population would have to be 10 feet away. So that's what those numbers mean, just a kind of, cool little science thing. Now with these here, okay, you have to, really? Oh, okay. Yeah, the handheld ones, they're different scales. So some of them, it's 14 inches. This one, it says 6 feet. So you have to look at the specific one you have. If you're using a handheld one, it's going to tell you how far this should be. Because if I do this, yeah, that's easy. Oh, I can easily see that. Some of the ones that you have in your kit, it'll say 14 inches away, but this one says 6 feet. So really make sure if you're going to use one of these that it's the appropriate distance. All right. Now, if you're just kind of doing a general, medical exam, I got a 13 size foot, so Mike, come on up for me. I want you to stand here. Nope, face there. Right there, right, and I can kind of just figure out 1 foot, 2 foot, 3 foot, 4, 5, 6. And that's kind of an easy way to do it. In your office, I actually have a wall unit and I have a piece of tape. If you're doing any type of school physical or pre-employment physical, vision is one of those things that's really, really, really important, so you got to make sure you're at the right distance. If not, the exam could be nullified and you could be liable for, improper information. So, what I have them do first is I have them go ahead and cover an eye, pick an eye, any eye. I want you to go ahead and you'll assign them which way, where you want to start. Now, if he doesn't have corrected vision, and I would get that information from the history, I'll start him at 20/20. Maybe he can see it, maybe he can't. All right, Mike, so what I want you to do is I want you to read this bottom line from left to right.
D, E, F, F, G, T, E, C.
Good. If it's a wall unit, I like to step in front of it. Go ahead and switch eyes because I don't want them to memorize the pattern. Now, just as long as they get more than half of them, that's usually the standard. They don't have to get 100%. Usually as long as they're like, 60% or above. The DOT standard is 75. So just as long if they miss 1 or 2 letters, it's not the end of the world. All right, so now he switches eyes. I put it back up. Mike, I want you to read the bottom line right to left.
C, E, T, O, F, F, E, E.
Okay, good. Now, go ahead. I also add a third component, and this is something that's required by DOT standards. We need to do both eyes. You want to see if the patient has monocular vision, okay? Basically, is each eye, what's the visual acuity in each eye, and what is the visual acuity with both eyes together? So again, Mike, do me a favor. Can you read left to right the bottom line?
D, E, F, F, O, T, E, C.
There you go. And you'll basically document what he was able to do. Now, if let's say he only got, I don't know, maybe 3 or 4, and I'm really not convinced that it's that good, I'll go to 2025, have him do it again. I'll keep going up until he is able to achieve, like I said, greater than 60 to 75%. Okay? Now, another thing you'll notice, what do you think these are for? Does anybody know why these are here? Green, red?
Color blindness?
Yeah, check for color blindness, right? What color is this?
Green.
What color is this?
Red.
Good. And if you're doing a DOT exam, what else do you got to have them be able to identify?
Yellow. Figures.
Yellow. Traffic light. Right? Can the person drive? All right, so again, while you're here, assess for color blindness. See if they can differentiate red from green. Okay? All right, so that's how you do, have a seat. That's how you do the Stellan eye chart. Now, I gave myself a 0 because I forgot my equipment in my office. Can I borrow somebody's?
It's the older one though.
Was you only worried about their correct?
So that's a good question. Jesse asked, should I only worry about their corrected vision? And the answer is, it depends. If they are trying to qualify for, let's say, a particular job that requires them to drive, for instance, with DOT, and Dave, you have a pen light? With the DOT, if they qualify with glasses, then they must at all times drive with glasses, okay? Meaning that if they get pulled over and they don't have their glasses, they can face license revocation or significant penalties. So it's really important, like Jesse said, when you're testing it, make sure you're testing and you document this is corrected vision or uncorrected vision. So again, make sure that, you're wearing contacts. Do you wear contacts? No glasses? Okay, there you go. All right. Now, if they had laser surgery or laser eye surgery, basically it gets a little dicey. Yes, it's technically corrected, but it's not an adjunct lens, meaning that they can't take it in or take it out. That's permanent. All right, so what I do in those cases is I basically document 2020, 2030, exam done post laser surgery or whatever procedure they had. Okay? But good question. All right, so that's visual acuity. All right, we must want to basically assess, can he see? The next thing is visual fields. All right, and this is peripheral fields of vision. Very, very important to assess this, okay? Does anybody know normally what someone's periphery should be? Meaning that if I'm looking straight ahead, I should be able to see at what degree. If this is 90 degrees, this is 0 degrees, what should I be able to see?
85.
Well, that'd be amazing. Anybody have any idea? Should be greater than 70, okay? Why is that important? Again, it's a safety issue when you're driving, right? If you're driving, can you see something out of the corner of the eye? Or if you're walking, can you see something out of the corner of your eye? All right? So, unfortunately, too often we just teach it and we don't really give you any numbers on why it's important. Well, this is why it's important. If you're doing this, you want to document what their peripheral fields of vision are. Now, some people use their fingers. I like to use the pen. All right? I use a pen light. You're going to see why in a second because I just basically transitioned into the rest of the exam. All right, so patient instructions. Mike, what I'm going to do is I'm going to have you focus on an object in the brick wall there, okay? I'm going to take this pen light, I'm going to come from behind, and I'm going to start very slowly bringing it towards the front. What I want you to do is let me know when you see it, okay? So I'm looking at him because I want to make sure he's not cheating. Some people teach you to do it behind. Listen, I'm not here to judge, but you should never do it from behind, especially if you're doing a pre-employment exam, because what's to say that he's doing this, right? If you're doing this for a pre-employment exam, the person obviously wants to pass. So not only am I looking at the pen light, I'm also looking at his eye to make sure that he's not cheating. So he's always looking straight. So I start from the back, and I'm going to do it in 3 sections. Upper, middle, lower. Okay?
No.
Okay? It's about 70, 80. Okay? And I do it bilateral.
Is there any degree of saltiness to this? They could just be watching your arm, and when it gets bent, they could just say now?
Yeah, I mean, you know, sure, there is. That's why I do another one. Glad you brought that up. So this one is nasal field division. All right, so I do 2 different types. What is this? So, nasal field division. So Mike, now what I want you to do is go ahead with this, and I want you to cover your eye. Cover your right eye. Okay? Now, what we're going to do is I'm going to stand on the same side. He's going to stand straight ahead. Now, obviously, he's going to be looking at the nasal periphery. All right, so I start here. When do you see it? See it now. And it should be 45. Now, if you're really concerned that the person's cheating, what you can do, you can have different color tips. All right, you can have a tip on this that you can put, or you can have like a red pen or a blue cap pen. What color do you see? Oh, okay, great. So if there is definitely concern for that, that's kind of usually what you can do. What's the caps? You know, but that's a really, really good question. Let me show this side. So again, he stands straight ahead. Nope, just relax here. Don't worry about it, I'm just gonna do it real quick. So upper, middle, lower peripheral field division. Now nasal. Go ahead and cover.
Do you want me to say?
Sure.
Okay.
Might as well give you an exam, right? And again, it's about 45 degrees. Okay? So those are the 2 styles of visual fields we want you to do. Okay? So both peripheral and nasal. All right, let's take 30 seconds, digest everything so far. Like I said, this is a very technical exam. Does anybody have any questions up through this point? Okay? Derek, you got a instruction?
Nope.
Okay.
Instruction, sorry.
Yep, no problem. Okay. Believe it or not, we're going to do a few more technical pieces, and then the rest is just inspection with the internal eye exam. So let's keep moving forward. All right, so we tested his visual acuity with the Snellen eye chart. We just did bilateral peripheral fields of vision and nasal fields of vision. Okay. Now we want to move in to the extraocular eye muscles. Okay. I'm sure every person has had this done before, right? Doctor comes, they take a pen, and they do some sort of a pattern, right? Hopefully? Good. What you're assessing for is the extraocular eye muscles. Guys, remember how many you have?
6.
You have 6, right? Okay. So, does anybody remember, let's go with the cranial nerves. The superior oblique is cranial nerve 4. What muscle, oh, I actually gave that away, nice. Woo! What's the name of the cranial nerve that handles the superior oblique? The trochlear nerve. What about the abducens nerve? What cranial nerve is that? What muscle does the abducens nerve cover? Lateral rectus. All the others? Ocular motor. So you'll see here in the notes, SO4, LR6, AO3. No, it's not a chem equation, but it is superior oblique, cranial nerve 4. Lateral rectus 6. AO stands for all other 3. Okay? Why is this important? Well, again, while you're in your inspection, what happens if you see a drooping eye or a lazy eye? All right? Let's think about this conceptually, because I think too many times we just run through it and nobody really understands it. If I'm looking at his left eye, okay, his left eye, and I see his left eye really rotated towards the nasal surface. The iris is level, the pupils are level, but his entire eye itself, instead of being here, it's medially rotated, or rotated towards the nasal side. Let's think about that. Think about what we just talked about. Is there some type of palsy or muscle weakness that could cause that?
Deuce's nerve palsy.
Yeah, you're going to worry about, is there some issue going on with the abducens nerve, right? Because obviously the lateral rectus isn't firing. The medial rectus is overpowering. It's shifting that actual eyeball towards the nasal surface. So that's why you really want to make sure you remember these muscles, because again, guys, like I said before, a lot of the eye exam, believe it or not, has nothing to do with the visual acuity. Obviously, it's an important component of it, but we can get a lot of information, how his brain status is, how his neurological status is. You know, this is how early detection, this is really how preventative medicine is supposed to be. Can we kind of detect a issue that's starting to brew, and let's get this guy some help before it becomes a serious issue, all right? All right, so that's why looking at the eye position is important. All right, so now what I want to assess for is all 6 muscles working? Do they work in unison, meaning do they work together? Is there nystagmus? What do I mean by nystagmus? Right, they're like these cicadas, okay? They jump. What causes nystagmus?
Stroke.
Yeah, certainly neurological issues can cause a stroke. Inner ear issues cause a stroke. If you guys had me a year and a half ago, you would definitely see some nasty nystagmus in me. What else? You been drinking, sir? It's part of a sobriety check, right? So excessive alcohol intake is going to cause nystagmus. All right, that's what, you know, police officers are trained to evaluate when they're doing one of the things that they do when they're doing a field sobriety test. So we want to basically make a note where the nystagmus is. Now again, you know, being physician-trained personnel, we want to be specific. Is it lateral gaze nystagmus? Is it vertical gaze nystagmus? All right, so we want to assess. Is it in the right eye or is it in the left eye? How do we figure that out? We do the cardinal field of gaze. You're going to make an H, a capital H. I'll do it on both sides so everyone can see. All right, so Mike, what I'm going to have you do is keep your neck still. I want you to focus on the tip of my pen. Notice how I'm explaining exactly where I want him to be. If you just say, all right, just focus, well, where is he focusing? Is he down here? Is he up here? So I want him to be very specific. Excuse me. All right, so keep your head still. Focus on the tip of my pen. So I first start. I go up. Now I'm looking at both eyes together. And I'm looking to see if I see any nystagmus or fasciculations. Now the last thing I'll do is something called convergence. So I start to bring the pen close to the tip of his nose. And basically what I should see is the eyes start to converge towards the nasal surface and the pupils constrict. Okay, that's what I want to assess. Let me show this side of the room. Okay, all right? So focus on the tip of my pen. Now this would be horizontal gaze nystagmus. This would be vertical gaze nystagmus. Now again, if you're not sure, go back. Yeah, I'm not sure if I saw something there. So keep going until you confirm. Just don't do it for like a minute or so because the patient may get a little nauseous, okay? And again, just to show you guys what convergence looks like, he focuses, I bring it here, and you'll actually see the eyes start to converge towards the nasal surface. Okay, so that is extraocular eye movements. All right, any questions so far? Let's recap. outside of inspection, we started with visual acuity. We now have visual acuity with Snell and eye charts. We have visual fields. We did both peripheral and nasal, right? Okay. Now we just did extraocular eye movements or the cardinal field of gaze. Okay. Accommodation and convergence, that's what this is called. All right, now let us go into direct and consensual light reflexes. I'm sure everyone's had the light shine into their eyes before. What should happen when the light is shined into the eyeball? The pupil should constrict, right? Why? Well, the lens obviously doesn't need that amount much light, so the muscles actually start to constrict. Okay? Should the pupil constrict on the opposite side? Yes. They should. If not, we got problems.
I said that for the video.
All right? I didn't even hear you, so you said yes, right? All right, so again, he's going to focus on something. Mike, do me a favor. With your hand, can you just do this? All right? So what I'm going to first do is assess direct light reflex. I come from the side. Do not shine it like this. Come from the side. And that's it. That's all you'll need to do. All right? So I come from the side. I see it constrict. I take it away. I look at the other side. I see it constrict. I take it away. Now, direct consensual, you can relax. Direct consensual, so direct is cranial nerve 2 and cranial nerve 3. Which makes sense, right? Cranial nerve 2 because the eye has to interpret the information, and cranial nerve 3 controls, I know we're really digging deep right after spring break, but what muscle? What muscle's in the lens? What are they called? What controls it?
Ciliary.
Ciliary. Yeah, very good. Right? So remember, ciliary muscles are also on the ocular motor nerve. So that's why direct light reflex, the eye has to interpret information, cranial nerve 2, and then it has to react to the information, cranial nerve 3. Well, again, there is on the same circuit, so whatever happens here should happen on the opposite side. All right, now, what cranial nerves would be involved with the consensual light reflex? So I shine into the left, I'm looking at the right. What cranial nerve am I assessing on the right? Is it 2 and 3 or is it just 3? Is it 2 and 3? 2 and 3. It'd be 3, right? Why? Because the light is not actually going into the opposite eye, right? So the information is not being processed through the opposite side. All right? So, come to the other side, so this side can see, do the same exact thing. Come from the side, check is direct, and check is consensual. All right? That is what we do with direct and consensual light reflexes. There's a condition called Pearl, P-E-A-R-L. Not Dr. Pearl, but Pearl. Anybody ever heard of that mnemonic? Pupils equal and reactive to light, which means is that the pupils should be equally constricted. They should both constrict at the same time to light. If not, then again, in the absence of some known, ophthalmological condition, you want to have that person referred. And if the symptoms warrant an ER, you're really suspecting a closed head injury, then you refer them to the ER. All right, pupil constriction. So just so you guys know, in closed head injuries, pupils dilate. All right, there's uneven, there's uneven dilation. Usually one side is significantly dilated. And when I say dilated, I mean it's like the size of a dime. All right, I've had a few in my years on the ambulance. I mean, it's pretty obvious, but again, something that you don't want to miss. All right. Any questions to this point? It's a lot of stuff. I mean, I know. This is probably one of the more complex exams we're going to do all semester.
I know Pearl Law with an A for accommodation. Can you explain that?
You can add the accommodation. Yep.
Can you explain what that is? Or
The accommodation. That's what we did here.
oh,
Yeah.
Okay.
Yeah. Okay. All right. Let's now go over your panoptic. You guys got the fake eye, that cube?
Yeah.
You guys probably wondering what that is? Good. So that fake eye is actually what you're going to practice on, because it actually mimics the inside of an eyeball. Okay? So this is your,
I don't know what you're talking
can someone show, yeah, so everyone knows the cube?
about.
Did they get one?
Yeah, they got one.
Yeah, right?
With the eye chart.
Yeah, that. Mike's holding it up.
So.
Yeah, it's like a cube. The reason why I ask is because I know some people, like a couple weeks ago, were asking what it is. Well, that's what it is. Okay. So, this is the head is the same for the otoscope. This is your ophthalmoscopic portion, okay? It just connects like your otoscope does. All right? This piece here goes over the front, and it just kind of snaps in. All right? This is where you would actually, person's eyeball is going to go in this. All right? Turning it on and off is the same exact thing you do with the otoscope, okay? Push the green button, you'll have some kind of a light source. All right, so let's focus a couple of things. All right, I'll show you in a sec. All right, you'll see here, this is your focusing cap. So what everyone's gonna do,
I have a completely different one than that.
perfect. All right, everyone may have a little different variation, so you gotta find your focusing, your focusing lens here.
Mine's a turning side on the side.
Gotcha. So what you do is you pick an object, again, 6, 10, 12 feet away, and then what you want to do is, using this, you start manipulating the dial until you can see it nice and clear. Okay? So you got to make sure that your ophthalmoscope is focused before you start using it, or else everything is going to look all distorted. Now, here's a suggestion I see everybody doing it. Don't do the magic squint. Relax the opposite eye. All right, you can gently close it. And again, don't push the ophthalmoscope against your eye. Because again, it's just going to blur and distort the vision. Okay? So once you go ahead and you focus it, you're ready to go. Now this thing has some pretty cool features. Now, personally, if you look, and if everyone just kind of shines the light into their hand, this bottom switch here will actually manipulate the lens, or I should say the light source. That's way more technical and advanced in the context of this course. Do you get into the different shades in the lecture portion, or?
No, we
Yeah.
stick to the one with the green line.
Yep, exactly. Yeah, like Doc said, the green line's going to be dead center. That's how you know your light source is. Don't touch it unless you go for some advanced ophthalmological training. Okay, so once you're focused, okay, making sure that the green line on the bottom dial is center, now you're ready to perform the internal eye exam, okay? All right, we're gonna keep the lights on for purposes today, but you do wanna do this in a dark room. Why? Because you're actually going to be looking through the pupil. That's where you're gonna see the internal structures. So, has anybody ever been to the eye doctor and they put the drops and they dilate the eyes? That's why they do it, right? So they get to cheat. So the ophthalmologist cheats. They make your eye, your pupils very, 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 very wide to the point where you're blurry, so you can't drive home. They do that so they can easily assess it. In a dark room, yeah, they're not going to obviously get to the stage of chemical dilation, but it'll be pretty effective. All right. So I have a couple of pictures that we'll work through, and then unfortunately we probably won't get any time to practice today, but that's okay. All right. So here's how you do it. If you're going to assess the left eye, you hold the ophthalmoscope with your left hand. All right. I like to stand at a 45-degree angle. Mike, you're going to focus on something over my left shoulder. Okay. I turn the light source on. Left hand, left eye, left eye. Follow what I'm saying? Don't do. If I'm assessing his right eye, or I should say his left eye, don't have the machine in your right eye, right hand. So keep everything consistent. If it's the left eye, it should be in the left hand, and I should be using my left eye. All right? So I take my thumb, and I very gently expose, or I should say I lift up, and then I come nice and close. And you're literally just going to move in until you can start to see some of the internal eye structures. Now, obviously, I'm not going to spend the next 15 minutes, and you guys are going to watch me just do that, so I'm going to show you what this should look like. One of the things you're going to notice is when you do it, all right, on Thursday, before you actually get into the eye, you're going to see a red dot. That's called the red light or the red dot reflex. It's very, very normal. It should be there, okay? So when the room is dark and you guys are practicing amongst yourselves on Thursday, all right, when you're here, the light source is on, where the actual pupil is, it's going to be red. We'll see that. That's a normal finding.
All right? Flash pictures.
What's that?
When you take a picture and everyone's eyes are red in the picture.
What, it shouldn't be, or what do you mean?
I'm saying, is that the same thing that happens when you take a flash
Oh
picture?
yeah, I'm sorry. Yep, exactly. Now, the only difference is if you take a picture and it's not there, doesn't mean anything. It just means that you're using a good camera. The red dot reflex should always be there. If it's not, you got to worry about cataracts. You got to worry about retinal detachment, and the one I always love chuckling, Dr. Sherman always puts in, glass eye.
We all have those glasses.
So, you know, it's important. If you don't see the red dot reflex, well, yeah, a person with a glass eye is not going to have it. So, when the pupils are nice and dilated, all right, so I want to kind of direct their attention to the screen as we walk you through a couple of structures. This is what you're going to see, all right? This is why when you guys go home today, tomorrow, like I said, you're probably going to be buried in 15 inches of snow tomorrow. So what better thing to do tonight than to take your little cube and practice, right?
Study for testing.
This is what you're going to find. And guys, this is a Google image. This is definitely in your books. All right, so where are we? This is the nasal side, okay? This is the lateral side, all right? So this would be a left eye, okay? Let's go over some of the important structures I want you to focus on. We're going to focus on this thing here. This is called the optic cup. Does everybody see how it's kind of shaded bright? You can also see the blood vessels. All the blood vessels are converging into this location where my cursor is. Everyone see that?
Yes.
Yes or no?
Yes.
Okay. The optic cup is where the optic nerve penetrates. It's where all the great vessels of the eye go into. The optic cup is a blind spot. Okay? So there's no photoreceptors, there's no cones, there's no rods. Why? Because all the nerves and vessels penetrate through that structure. So naturally, the optic cup should be small. If the optic cup is significantly larger, well, that's something called glaucoma. I'll talk about that in a second. So, I should get a better, here we go. So, here's an easier image. You see how it's nice and bright here? That's the optic cup. And then you'll see it's a little darker shaded. That's the optic disc. Okay? So again, here's the optic cup. Everyone see that? And then it gets a little darker. This whole big structure is the optic disc. So the optic disc should roughly, and again, you know, they usually use the 2 to 1. That's pretty good for our purposes. If you really want to get nitty gritty, it's like technically, the optic cup should be like 4/10 of the optic disc. But bottom line, the optic disc should be twice as large as the optic cup. All right, just kind of use that, and it'll help guide you. Well, what happens if you're looking here, and this big old bright spot is all out here? Well, that's glaucoma. Has anybody ever heard of glaucoma? Glaucoma basically happens when there's increase in intraocular pressure, okay? And basically it leads to blindness. Because what did I tell you? This is a blind spot, okay? So obviously, the brighter it is, that's an indication that the nerve cells that are surrounding that have died, and your blind spot, if I may, is getting bigger. So that's a problem. So glaucoma is a very, very, very serious condition. And if you're not sure, if you're looking in here and it is like bright white, meaning you can't even see the optic disc, that person needs to go to an ophthalmologist. They need to be tested for glaucoma. Very, very serious condition. Okay.
Specifically an ophthalmologist.
Ophthalmologist, yep, an eye specialist, yep. The other thing I want to bring your attention to is this. You see here on the optic disc, you see how nice and smooth these edges are? Good. Well, in patients with closed head injury, those edges aren't crisp, they're blurred. And believe it or not, that's actually the first sign that you can see. There are some studies that they put it up, it's actually more sensitive and specific than a CAT scan. So, very hard to find, obviously, but if you're just doing a routine eye exam and you kind of see some blurring of the optic disc, yeah, that person needs to get their head scanned because that's a sign that there's, again, some type of increased intracranial pressure, all right? All right, so let me zoom out. All right, so does anybody have any questions on the optic cup and the optic disc? All right, so that's why we're looking at that. That's why we're evaluating it. All right, let's look at the whole structure in general. You see how it's nice and kind of this creamsicle color? Bless you. Right, it's kind of like a nice orangey creamsicle. That's normal. This structure is called the fundus. All right, your fundus should have this nice, normal creamsicle color. There's a couple things that you're going to see in the notepad. All right, if you see something known as cottonwool spots, you see how there's white spots here? They shouldn't be there, right? We can see the optic cup, we see the optic disc, but there's these white spots everywhere. Well, early onset or uncontrolled diabetes or hypertension can give you those. So again, that's how one of the things, just by doing an eye exam, you may be able to see, an endocrine condition or a cardiovascular condition based on this. The fundus, let's say it's significantly erythematous, meaning it's red, it's bright red. Well, that means that, hey, there could either be some kind of significant infection or hemorrhage. Again, that's not good. That patient needs to get referred, okay? So let me go back to our portion here. You can evaluate, now I'm not going to get into the specifics today because that's way too much overload for you guys, but you have your vessels, veins, and arteries. Now, here's the deal. In the eye, the veins are actually larger, okay? So you're not going to necessarily see color differentiation. It's not going to be blue, right? It's not going to be like, when you're in your anatomy lab. So the larger diameter vessels are actually veins, and the smaller vessels are actually arteries. But what I really want to direct your attention to is this spot here. You see any blood vessels here? No, right? This is an avascular region. This is known as the macula. Just going to throw it out there. Anybody have any idea what is the macula?
High sensitivity.
Hmm?
Like most visual acuity.
Bingo. Highest central visual acuity. This is where you have a significant amount of photoreceptors. So this is basically, like he said, sharpness of vision. I can differentiate various colors and whatnot, all right? So the macula, when you're looking, or when you're looking in your fake eye, you'll see a spot or a region. It's going to be lateral, and it's going to have no blood vessels. That's the macula. Now, what happens if this gets really dark, really large, really black? That is what you call macular degeneration. Has anybody ever heard of that before? Yeah, happens in elderly folks. Their sharpness, their color acuity starts to decrease. This is what macular degeneration looks like. You see how significant and dark that this portion is? You see how large it is, first off? That's not good. So this is what macular degeneration is going to look like. All right, again, we can see what looks like this nice bright portion here. What is this called?
Optic cup.
The optic cup, very good. What's the outer ring?
Optic disc.
Good, good, right? And then obviously the macula, which is very, very abnormal. All right. You can even see some dark spots here on the fundus. All right. All right. So that's, you know, for I think that's good for today. Like I said, it's definitely an overload.